In this video, we demonstrate a technique using a Mako robotic system to perform bone cuts for an anterior closing wedge osteotomy of the proximal tibia. These are our disclosures. Excessive posterior tibial slope is a risk factor for ACL graft rupture. Anterior closing wedge osteotomy aims to reduce the tibial slope and has a role in ACL revision surgery. It is technically demanding and varying techniques are described. Key challenges include injury to structures, accuracy, and inadvertent coronal plane adjustment. Robotically assisted knee replacement provides high levels of accuracy. This proof of concept uses the established precision of a robotic cutting system for a new application to perform an anterior closing wedge osteotomy. The system comprises a robotic arm, an optical array, and a computer. A saw of 2 mm thickness attaches to the robotic arm, which has a limited excursion. Its stiffness allows for greater accuracy. Tracking arrays are fixed onto 3.2 mm pins placed in the femur and tibia. These feed back to the optical array. Preoperatively, the patient undergoes the routine Mako protocol scan for a TKR of a CT from hip to ankle. A product specialist defines the margins of the bone to create a model used for intraoperative referencing. The tibial implant is superimposed in blue in 3 planes. The planning screen of the sawbone shows 4 degrees of native varus. The inferior aspect of the tibial tray in its atypical position acts as the surrogate for the osteotomy plane. For our purposes, the keel of the implant does not apply. We can move the base plate of the tibia in 3 planes as shown to set the appropriate hinge point and 2 cut planes for the osteotomy. For a supratubical osteotomy, we rotate the base plate around the chosen hinge point. We can replicate or alter coronal alignment, or drop the base plate down to adjust the hinge point. Note the PCL recess on the tibial tray. The saw boundary can be extended beyond this. Having confirmed our hinge point and plane of the first cut, we rotate our tibial implant 14 degrees for the second cut, resulting in a 10-degree closing wedge. The 2 mm firth of the saw blade must be accounted for. The superior cut is dropped down by 2 mm as illustrated. Once this is performed, the base plate is re-elevated before rotating around the hinge point to set the second plane as shown. Pins and arrays are placed and the hip center is confirmed. Registration is performed using blue and green probes to reference off anatomical landmarks. Unlike knee replacement referencing, we have confirmed in the sawbone model that we can register only anterior bony landmarks that would be encountered in an anterior closing wedge osteotomy. Protective or haptic boundaries of the saw are set. The blade cannot move beyond this virtual boundary, offering protection of structures. Depressing the trigger positions the robotic arm to the plane of the first osteotomy. The saw blade cannot deviate from this plane. After confirming base plate position and a sagittal cut angle of 4 degrees, the first cut is made. Although currently designed for knee replacement, haptic boundaries can be customized to account for the patellar tendon in completing the cut laterally. Following the first cut, the base plate is raised 2 mm and the slope of the second cut is changed to 14 degrees. Here is the plane of the second cut, and here the second cut is performed. The bone cuts are precisely replicated against computer modelling. The posterior view shows an intact hinge point and posterior limit of resection. The same principles apply for infratubical osteotomy. Rotation of the tibial component is set at 30 degrees for the inferior cut and 20 degrees for the superior cut. Clean compression is seen. Here we show the safety of the haptic boundary in trying to create a hinge fracture. One benefit is to accurately make coronal plane changes. This is a recut correction of pre-existing varus which is done with divergent cuts. We have leveraged accuracy and precision of robotic surgery in an anterior closing wedge osteotomy, and this proof of concept may have future clinical application. Thank you for watching.